Hello and welcome back to microbiology. We're going to be doing disease 2, which is going to cover infections of the cardiovascular and lymphatic system, as well as the respiratory system. So the first thing we need to talk about is endocarditis, which is going to be inflammation of the inner linings of the heart. We see two different forms, acute and subacute, but overall it's important to remember that damage to the heart typically does not repair, and as a result, endocarditis can leave people with lifelong disability. Again, since endocarditis can come in acute or subacute forms, we'll see different signs and symptoms. Again, the symptoms for acute endocarditis, again, start off initially with your normal infection symptoms like fever, but then we start to see, since we have this rapid increase in microbes quickly, the abnormal heartbeat and often symptoms that resemble heart attack. That can even progress into an overall abdominal or side pain. The symptoms of subacute endocarditis, though, are again similar to acute, but since it's a slower progression, we often do not notice them as quickly. So here's the summary of acute and subacute endocarditis. So let's talk now about septicemia, and this is whenever microbes again reproduce actively in the blood. We do have the initial signs and symptoms of infection like fever, but since this is an infection of the blood, it will affect all the different areas within the body. So we see things ranging from altered mental state through signs and symptoms in the gastrointestinal tract. Let's talk a little bit about endotoxic shock. Since gram negatives actually have endotoxins consistently inside of them, whenever we actually attack and destroy gram negatives, we see those endotoxins released. And the result then is actually a stimulation of the inflammatory response. But this overstimulation of the immune system could literally lead to a major issue in terms of the body goes into shock. And ultimately that could lead to death. So here's the summary of, again, septicemia. The plague is going to be an infection caused by a bacteria known as Yersinia pestis. But this bacteria can cause infection in three different ways. We have pneumonic plague, bubonic plague, and septicemic plague. Whenever we talk about bubonic and pneumonic, it's important to understand that they can progress to septicemic plague. And whenever a patient has septicemic plague, their chance of death is very high. Without treatment, it is a guarantee. Even with treatment, though, there's a 50-50 chance that they make it. Let's talk about, though, the initial infections with pneumonic and bubonic. Bubonic is going to come from a bite that allows for the pathogen to be entered into that extracellular space. From there, it can jump into the lymphatic system and travel to the lymph nodes, where it causes inflammation and necrosis of the lymph node. We call this a bubo. At this point, again, mortality rate is going to be around 15%, but it's important to understand that this will, if untreated, potentially move to septicemic plague. Whenever we see that transition into the blood, we also see the transition into the lungs, and at this point, the bubonic patient can pass the infection via the air and cause pneumonic plague in someone else. Again, the microbes are coming into the respiratory pathway. One of the things to note here is pneumonic plague is much quicker to moving to septicemic plague, and as a result, pneumonic plague victims often die more quickly than bubonic plague victims. So here's an illustration of the enlarged necrotic lymph nodes. We call them, again, buboes. Believe it or not, Yersinia pestis is still found in the United States, and there are actually significant numbers of cases each year. The idea, though, is we're better prepared for this, and it's actually pretty easily treated through typically antibiotics. And so the idea here is rarely do people actually die. I want to point out that this is, again, typically isolated to the west, but there have been cases towards the east, but many of those cases, again, were people visiting the west coast and bringing the infection back to the east. So here's this illustration of the bubonic versus pneumonic plague. Notice in this scenario, the vector is actually going to be the flea. The reservoir is going to be the mouse, or any real rodent like a ground squirrel or chipmunk. The idea, though, is the flea can bite the infected reservoir, or host in this case, and then bite a person. This gives the person bubonic plague, as again the bacteria would be moved from the extracellular space into the lymphatic system, resulting again the buboes forming along the lymph nodes. And again, this individual could then have the bacteria start to grow in the respiratory pathway that allows for them to express it out to another person. That individual contracts pneumonic plague, and it's again a shorter distance from the lungs to the blood, and as a result, pneumonic plague tends to kill much more quickly. So here's that summary sheet for plague. So let's move on to tularemia. Tularemia is going to be caused by a bacteria known as Francisella tularensis. What makes this more interesting is the fact that it actually has a very low infectious dose, or ID. This one, again, would be so low that it resembles levels usually held to the standard of viruses. And so the idea is very few bacteria have to be transmitted before it causes the infection. As far as the signs and symptoms, they're pretty vague. We see things like headache, backache, fever, chills, malaise, and even weakness. But then we can see signs like ulcerative skin lesions that might start to suggest a probable cause. And without treatment, we do see a mortality rate of around 1 in 3. And so the idea here is, in places where this is endemic, we should be looking for it as a possible cause. But let's talk about that for a minute. This was more commonly known as rabbit fever in the past, because again, rabbits were a common reservoir for it, and even just handling an infected rabbit was enough to cause infection. But nowadays, very few people hunt and interact with rabbits, and as a result, we've seen that mode of transmission to be less common. Nowadays, most cases of transmission are actually through, again, a vector like the tick. So where there are large amounts of ticks, that's where we see larger amounts of tularemia. And unfortunately for us, we are in a hotbed for Francisella tularensis transmission. And so naturally here, we need to look for these signs and symptoms to make sure that people are not going to fall ill with this disease. As I said before, Francisella tularensis is a causative agent. It is a gram-negative facultative intracellular parasite. So this is a small bacteria that lives inside of your cells. And like I said, the infectious dose could be down around 10, which is naturally where viruses are more commonly found. This is a very large bioterrorism concern because of how easily you can contract this disease. But overall, we haven't seen any active uses as a bioweapon. And the reservoir for this tend to be small rodents and mammals. So the idea, things like skunks, beavers, possums, foxes, and rabbits and rodents are our big concern. Here's that summary sheet for tularemia. Lyme disease is going to be a pretty important topic that we'll spend some time on. Lyme disease was initially discovered in Old Lyme, Connecticut in the 1970s. There was actually basically an outbreak of symptoms of juvenile arthritis, and so the idea was there was something clearly causing this issue, and so the CDC sent a team to investigate. Upon getting there, they couldn't figure out the exact cause in terms of whether it was bacterial or viral or what, but they did note that the connection was tied to bites from ticks. And it actually took a very, very long time before they actually figured out the causative agent, which was Borrelia burgdorferi. So one of the things that was noted was this again was a slow-acting progressive disease, but many times at the bite site where the pathogen was introduced, they'd see this bullseye rash that they called erythema migrans, or the migrating rash. We also see kind of these varying systemic signs and symptoms, things like fever, headache, stiff neck, dizziness, issues with cardiac and neurologic outputs, even again that arthritis that we just discussed. But as stated before, again, it took a long time to actually figure out the cause, which was a spirochete named Borrelia burgdorferi, which was named after the discoverer William Burgdorfer. He, a physician, would take and pull tissue samples and kept noticing this spirochete abundant throughout the body, and he speculated this to be the cause. So ultimately, again, spirochetes are very concerning to us because of their shape, and their internal flagella allows them to move pretty freely through many tissues. and as a result we get that systemic infection that we just described. So I want to point out that there is going to be some degree of ability to change surface antigens with Borrelia burgdorferi, which means it can actively kind of hide from the immune system, allowing for a prolonged infection. So in order to fully understand this, we'll have to understand the means of transmission, which in this case is vector-borne. This pathogen is routinely found in deer and rodents and mammals, but has to be typically picked up by a tick and carried to a person. So there are no ticks that will be born with this. Again, all larval ticks, which by the way have 6 legs, again will not have the pathogen in them, but upon the first blood meal they can pick up the pathogen and become an infected larval tick. Interestingly enough, ticks need a blood meal to move to the next life stage. So we see again that larval tick turns into what is known as a nymph tick. And these nymph ticks are still very small, and as a result, again, can routinely get on a person and bite them and feed on them long enough to actively have transmission to the person. The idea is it typically takes 2 to 3 days for the bacteria to be inserted into a person. And these ticks, these nymph ticks, again, would be small enough to do so. But the idea is then they, in their next progression, would become an adult tick. And that adult tick, its sole purpose is reproduction. And so the idea is, again, these ticks, the adults, will make offspring. But do not forget, the offspring are not born with the bacteria in them. So they must feed always on an infected host to pick up the pathogen to pass to a person. So we found out pretty quickly that one tick species in particular was capable of transmitting this pathogen, and so that tick is called Ixodes scapularis. What it is, again, is the black-legged or deer tick, and again this tick has a very specific range. The Lyme disease table is listed here. Again, I want to really stress to you that treatment is pretty easy through doxycycline or amoxicillin, and usually quite effective. And so the idea here is damage that occurs to things like the joints or heart or nervous tissue could linger because, again, those tissues rarely regenerate. So let's move on to infectious mononucleosis. That's actually caused by a virus known as the Epstein-Barr virus. This thing is actually going to be super common. Estimates put upwards of 96% of the world's population being infected with EBV. The idea is most of us experience this, but this thing is also going to linger because it is technically a herpes virus. And so the idea is this pathogen will enter the body, potentially cause infection, but then hang out the rest of your life. So Epstein-Barr, again, causing mononucleosis. So let's talk for a little bit about anthrax. We've already introduced anthrax to cutaneous anthrax, but a quick reminder, the cause of anthrax is a bacteria known as Bacillus anthracis, which is a gram-positive endospore-forming rod routinely found in the soil. I want to again remind you that anthrax could cause multiple diseases. We talked about cutaneous, but anthrax could also cause gastrointestinal anthrax or even pulmonary anthrax. The idea here, though, is once the anthrax gets to the blood, you're incredibly likely to die. And so naturally, the more dangerous forms include the cutaneous and pulmonary. The gastrointestinal anthrax, usually unpleasant but not lethal. There are, again, dangerous toxins produced by Bacillus anthracis that will cause tissue damage, so it's not uncommon to see tissue necrosis with these infections. So here's that summary of, again, anthrax. So let's move on now to hemorrhagic fever diseases. As the name suggests, they're going to cause hemorrhaging and fever. These are all viral, and actually some of the worst stuff in existence. These are all BSL-4 pathogens. Ultimately, again, these things would usually be geographically isolated, but due to the change in global warming patterns, we're seeing this starting to spread. So let's move on to dengue. Dengue is going to be a single-stranded RNA flavivirus that's transmitted specifically by Aedes mosquitoes. This is often called break-bone fever because not only are you bleeding from every hole you have and having an extensive fever, it's going to have pain associated with it that's connected to the pain tied to breaking a bone, right? So you're going to be in incredible pain. This is typically endemic to Southeast Asia and India, but we have seen epidemics in Central and South America, the Caribbean, and Mexico. So this thing, again, really likes to hug the equator, and as temperatures increase, potentially can move northward. Dengue, again, has very high rates of morbidity and mortality, which is why, again, it's a biosafety level 4 pathogen. Ebola and Marburg, again, two very dangerous filoviruses in the family Filoviiridae. Their symptoms very similar to dengue, but one of the more important things here is there's a significant mortality rate for Ebola. Even roughly 5 years ago, we considered the mortality rate for Ebola to be 97%, but we are seeing that there are some treatments that are helping, and thus we've brought mortality rate down to around 70%. The big concern here, again, with these hemorrhagic fevers is they cause capillary fragility. So wherever capillaries are located, we can see pooling of blood. And so naturally, we see bleeding from every orifice that we have. Lassa is another hemorrhagic fever that's caused by an arenavirus. Another name for this is the Argentine hemorrhagic fever or the Bolivian hemorrhagic fever. The idea here is this thing can be found in regions that straddle the equator, but have been imported to countries even well to the north, like the UK. So naturally, chest pain, hemorrhaging, sore throat, back pain, vomiting, diarrhea, even encephalitis can happen. But what I want to point out is two different things. The first thing is patients who recover suffer deafness, so they lose hearing. And then in terms of issues with pregnancy, pregnant women, there's 95% of the cases we see the spontaneous abortion of the offspring whenever a woman who's carrying becomes infected with Lassa fever. So here's that summary of these hemorrhagic fevers. So let's move on to non-hemorrhagic fevers. And to really make this simple, they're fevers. Whether or not you're run-of-the-mill acute fevers, these tend to be more of a chronic fever. So let's start off with brucellosis. Brucellosis, also known as Bang's disease, is caused by a bacteria known as Brucella. This is a gram-negative coccobacilli that often loves to live in phagocytes. Again, this thing can prevent fusion between the lysosome and the phagosome, and the result is they reproduce actively in the phagocyte. This is considered to be a bioterrorism agent because of their ability to evade phagocytosis. As you can see here, we're not talking about just a short run of fever, we're talking about a continuation of fever. Notice we only really spend about 3 days here and 20 out of 21 days under what is considered fever range. So let's move on to a new pathogen, which is Bartonella hensleyi. Bartonella hensleyi causes something called cat scratch fever. Again, for a very long time we called this fever, but we more recently changed the name to just cat scratch disease because fever is only seen in roughly 1/3 of the patients. But what we do characteristically see is at the site of a bite or scratch from a cat, we'll see a cluster of papules start to develop, and then lymph nodes really start to swell as they fill up with pus. The idea is this, again, very unpleasant disease, and these symptoms tend to take time, so it's usually 1 to 2 weeks after the bite or scratch. And if you believe, again, that you're safe from this, do understand this is found in roughly 40% of all cats. So all it takes is a simple bite or scratch. Let's move on to another Bartonella species known as Bartonella quintana. Bartonella quintana causes something called trench fever. Interestingly enough, what carries quintana is going to be lice. And really, the transmission of the infection is through the feces of the lice. So you need a wound, and then the lice need to defecate in the wound. And so this really became a big problem during World War I, whenever they introduced trench warfare as a common practice. Everybody stuck in the trenches for long periods of time, had poor hygiene, which allowed for lots of lice. But again, the nicking and cutting from working with barbed wire allowed for now a portal of entry. So this became super common during World War I. But trench warfare not as common today, and as a result, this disease has decreased significantly. But there are still some people at great risk, and that's the homeless individuals. Again, lice being super common in the homeless population and potentially being nicked up, scratched up by living out in nature, these individuals are at some risk. There are two other interesting tick-borne diseases that we should probably talk about. These are intracellular bacteria that are carried by the ixodes ticks, and they're Ehrlichia chafiensis and Anaplasma phagocytophilium. These two, again, are going to be carried by ticks, so they're tick-borne disease, and as a result are actually very common around here. But overall, most patients do not have any serious signs or symptoms and no long-lasting effects. So overall, a pretty minor infection. Babesiosis is going to be a protozoan disease that's going to affect red blood cells. It's going to be very similar to Ehrlichia and anaplasmosis and also be carried by ticks. The next tick-borne disease we're going to talk about is Rocky Mountain spotted fever. As the name suggests, we're going to see a spotty rash but also a fever. Unfortunately, though, the name is a little wrong in that the Rocky Mountains isn't the primary location for this disease. This disease is actually primarily seen in the central region in the U.S. In fact, it usually starts here in Missouri and works its way eastward towards Tennessee and Kentucky. As far as what carries this is going to be a hard-bodied tick. And the signs and symptoms initially start off very vague, but then a very distinctive spotty rash develops around 2 to 4 days after the initial infection. If left untreated, these lesions actually start to enlarge and become basically merged and then ultimately necrotic. The real concern here, though, is it has cardiovascular disruptions, and as a result, if left untreated, we see a mortality rate of around 20%, but even with treatment, we see mortality rates still around 10%. So here's again an example of a tick species that could spread this. This is a female dog tick, like what we have here in southern Missouri. And you can see behind the tick the spotty rash that develops. So this is a summary again of the non-hemorrhagic fever diseases. This is again a continuation of those non-hemorrhagic fever diseases. And then here's the last summary table of those non-hemorrhagic fever diseases. So let's show you again some more information on tick-borne disease. Notice this is a distribution of different types of tick-borne diseases. Things like anaplasma, again, primarily focused where we see the Ixodes scapularis tick, but can be found here in southern Missouri. We see babesiosis, again, following the tick-borne disease of the black-legged tick, so the deer tick. Same with Lyme's disease. But notice we have a huge amounts of centrally located diseases that again were associated with the tick species that we have here, and that is going to be again the dog tick and the Lone Star tick. So ehrlichiosis, Rocky Mountain spotted fever, tularemia, these are real concerns here. So let's move on now to something known as Chagas. Chagas is going to be another protozoan in the trypanosome group. Trypanosoma cruzi is actually going to, like African sleeping sickness, infect the blood. But the vector for this guy is actually something known as the assassin bug or kissing bug. And where the actual bite occurs from this bug is where the pathogen enters the body. And at that site, we see the formation of something called a chagoma. If you don't remember, oma means tumor or mass. And so the idea is where the bite occurs, you see this giant tumor or mass develop. Since this assassin bug or kissing bug has very small mouth parts, they have to bite where blood is close to the surface. So in and around the eyes, nose, even lips. Again, this is a common place for the insertion of Chagas. One problem is if this is again a long-term infection, that protozoa starts messing with the brain, heart, and intestinal pathways. And it is not uncommon to see a person drop dead because their heart stops beating. So you can see again the trypanosome in the blood smear. So you can see a flagellated protozoan in the blood would be a trypanosome. So here's that summary on, again, Chagas. So let's move on to malaria, which is actually a pretty big topic. Malaria is going to be kind of a cyclic disease that has symptoms ranging between 48 to 72 hour intervals. The idea is you're going to have a generalized malaise, fatigue, aches, and nausea with or without diarrhea. We also see things like fever, chills, and sweating. What happens is a protozoan is going to infect things like the circulatory system, and as a result, again, we see those symptoms being systemic. So we do see falciparum malaria, which is persistent fever, cough, and weakness for weeks. And then we see cerebral malaria, which is again going to be small blood vessels in the brain become obstructed, leading ultimately to potentially death. So naturally, cerebral malaria much more of a concern than falciparum. So let's talk about again the cause of this disease, which is again a plasmodium, which can again come in several different species, like Plasmodium malariae, vivax, falciparum, ovale, and knowlesii. The key to this disease, though, is it must be transmitted via mosquito. So a mosquito has to have the protozoan in it and then carry it to a host, where then the protozoans often take and reproduce in association with red blood cells, damaging those red blood cells. So as again we get that damage of the red blood cells, we see that we have situations where people become anemic. So naturally they would have lower ability to function. So again, that fatigue, that malaise, that general feeling of blah is really the accumulation of all this damage of the red blood cells. Ultimately, again, that accumulation of those damaged red blood cells and malarial products actually start to affect things like the liver and spleen, causing enlargement of these organs. Naturally, again, all these busted cells could actually cause, again, clotting in the brain, which results then in things like strokes. So what carries this? Well, this is specifically carried by the Anopheles mosquito. So the Anopheles mosquito is going to typically be found around the equator, and as a result, malaria cases tend to stay in these regions. But one of the things to understand is the sheer frequency of these cases. Every single year, there will be 200 million new cases, with around 90% of those occupying just Africa. In terms of deaths, we see around 500,000 to 1 million deaths annually. So this is a very big, serious, widespread infection that again affects huge amounts of people that do not have access to health care. So the name of the game here becomes prevention. There are two major things that we're trying to do. First off, if we prevent the mosquitoes from reproducing, we can see lower rates. So the use of things like insecticides, the elimination of standing water, or even the introduction of sterile male mosquitoes into the population could eliminate a good chunk of the cases. But there's something that's actually much simpler and much more affordable, which is the use of mosquito nets. A simple bed net could save a whole family for around $5. The illustration here is, again, if you keep the mosquitoes away from people, the likelihood of transmission goes down significantly. So here's that summary of, again, malaria. Moving on to HIV. HIV was first isolated in the 1980s. It's a very unique virus in that it's a retrovirus that's capable of doing things like reverse transcription. This is a disease that will be chronic and progressive, and ultimately, again, HIV can lead to something known as AIDS, which is an immunodeficiency syndrome. The idea here is that as long as the virus numbers stay low, the likelihood of transmission, or the likelihood of moving into acquired immunodeficiency syndrome or AIDS, is very low. So keeping viral numbers low is what we want to do. As far as clear-cut symptoms, there's not a lot. We see some pretty consistent things like chronic diarrhea, excessive amounts of weight loss, and then an increase in infection tend to be common. But overall, each person would be different as this is affecting immune response. So let's look exactly at how this is going to work. So there are 3 lines that you should pay attention to. The first line is going to be the number of viral antigens. But if you recall, again, the antigens will be found on the virus. So this is really the number of viruses. Okay. The orange line is going to be the number of antibodies, which will help eliminate many viruses. And then the last line here is the CD4 T cell numbers. The idea is actually pretty straightforward. The initial infection is going to cause, again, lots of initial problems, and so we start to see this steady decline. But what happens is typically immune response kicks in, bringing the amount of virus down. But at some point, though, we see this scenario where now the virus is still here, but is not in huge numbers, but at the same time it's destroying T cells. At this point, these T helper cells are becoming so infrequent that we no longer have coordination of the immune response. And at this point, even though we have things like antibodies still present, we don't have any other features to help fight. And as a result, AIDS sets in as the HIV numbers start to increase again. So again, some general signs and symptoms here. We see initial symptoms: fatigue, diarrhea, weight loss, again, excessive amounts of infections, including opportunistic infections. But then we see that really huge issue at the point of AIDS, where now the immune system's so broken, now we have this significant immune deregulation, hormones become imbalanced, there's metabolic disruptions. We see, again, huge amounts of weight loss, diarrhea, huge amounts of infections, and ultimately then we start seeing lesions developing all over the body. The idea is AIDS is, again, a death sentence, but as long as we keep HIV levels low, the likelihood of transmission to AIDS is much, much lower. So let's talk about this as a virus. This virus is in the genus lentivirus. It is going to, again, be a retrovirus that does reverse transcription using the enzyme reverse transcriptase. HIV, again, comes really in two different forms, HIV-1 and HIV-2, but there are even subtypes, which means, like, for the development of vaccines, this makes it very difficult. Are there vaccines currently in the works? Absolutely. And will they make a huge difference? For sure. But there's not going to help everybody because there's so many variants. So here's some structural comparison in terms of the virus and what it does. So the virus is going to have GP120, which is going to interact specifically with things like CD4s. But what T cells did we say had CD4s? And the answer there is things like helper T cells, right? And so the idea here is we're really going to be focused as a virus on attacking things like those helper Ts. And so you can see whenever the virus gets in, it starts pumping out and reproducing different components that ultimately leads to the production of huge amounts of new viruses. And as long as, again, the virus is present, we will have this continual destruction of those helper Ts. So let's discuss HIV transmission. One of the things you should understand is it's somewhat difficult to contract HIV. You need a lot of things to not go your way. But once you get HIV, there's no clearing it. So it's important to always use protection. Where do we find these things? Well, honestly, the virus is found in any bodily fluid. But I want to point out, though, we have something like infectious dose, right? Where you have to have so much of the virus before you're likely to become infected. So really the source of infections become sexual fluids, blood, and breast milk. So how common is HIV? Well, since the beginning of the epidemic in the 1980s, there have been 60 million cases. But in terms of deaths, we've seen around 30 million have died worldwide. The illustration is we think roughly right now there are 37 million people infected, with around 1.2 million infections currently in the United States. 6% of those people, though, are unaware of it, and as a result are not taking steps in terms of protection, and thus the risk of spreading is still there. So here's again that kind of breakdown of whom's at greatest risk. One of the things I really want to stress to you guys is that everybody's at risk. This thing started traditionally in the homosexual male population, but has easily been spread to the heterosexual population. The idea here is there are high-risk behaviors that increase your risk of infection significantly, which includes unprotected sex, including anal sex, because again, the limited lubrication allows for micro tears, rips, fissures that could allow for a portal of entry. And we told you sexual fluids could be the source of the infection. And so the idea is whenever we have under-lubricated and unprotected sex, we open up for a higher risk of infection. I also want to point out injection drug use is another common way this thing's transmitted. So the sharing of needles. It's very important, again, that needles are not reused. That, again, every person uses new needles. So let's talk about how we culture and diagnose HIV. Overall, again, a patient is diagnosed with having HIV whenever we detect the virus in the blood. So how do we detect the virus in the blood? Well, things like an ELISA or an enzyme-linked immunosorbent assay. We also have rapid antibody tests that we can use and latex agglutination. The idea here is if we find the virus in the blood, we say that person has HIV or is being HIV positive. But this is not the same as having AIDS. For you to be considered for having AIDS, you must meet one of these three criteria. If you have a CD4 count fewer than 200 cells per microliter of blood, if you have a CD4 cell count fewer than 14% of lymphocytes, or if you experience one or more of the CDC provided list of AIDS defining illnesses, we're considering you to have AIDS. So the idea here is, again, you must have the virus and you must meet one of these three criteria before you're reclassified as having AIDS. So naturally, prevention becomes the thing that we're most concerned with. The best protection you could have is not having intercourse with someone that is infected. But barrier methods are also very necessary in having safe sex, period. So use of condoms and barrier methods is very, very important in decreasing the risk of HIV transmission. Not sharing needles or using clean needles is very, very necessary as well. HIV positive individuals with unaffected partners should begin a regimen of antiretroviral drugs to decrease the likelihood of transmission. And as I said before, there are huge amounts of vaccines currently in the works that could bring these numbers down significantly. So let's talk about the treatment for HIV, because the idea here is we need to keep viral numbers as low as possible for as long as possible. So treatment should begin immediately. We need to, again, use a cocktail of antiviral drugs that will decrease the amount of viruses present, preserving the immune system as long as possible. Here's that summary on HIV and AIDS. So let's move on and show you the summary for this chapter. So again, the cardiovascular and lymphatic system diseases. Again, there will be several of these things that we did. Those are the ones that you should know. Any of these that we didn't spend time on, again, those are things that you should probably ignore. And the visual summary of, again, where we see these things. So let's now start discussing the common cold. This again is going to be a respiratory infection, often called rhinitis, which is nose and inflammation. The idea here is that the common cold is going to be common, roughly 67 million colds per year, but at significant cost in terms of lost production and literal medical costs. The idea is there are signs and symptoms you guys all know about because you've all had colds. The understanding here, though, is that this infection could lead to other infections, so it's important to take some time, rest, and hydrate. So what causes the common cold? Well, lots of things, but a good chunk of these things are going to be rhinoviruses, coronaviruses, and adenoviruses. Ultimately, symptoms usually are due to the immune response to the virus, so those things that you deem as being the signs and symptoms of a cold is really just immune response. Here's that summary for, again, the common cold. So let's move on to sinus infections. Sinus infections can cause inflammation of the sinuses. The idea here is that this can be caused by a variety of things, including allergies or even infection. The progression for this oftentimes is a cold could lead to then the sinus infection, as we've been able to fail to move the mucus out of the body. And as a result, you get sinus pain, nasal congestion, pressure, headache, and or toothache. And ultimately, you get this discharge of often a colored mucus, which illustrates, again, potentially infection. So what causes things like sinus inflammation? Well, things like viruses, as we said, again, like the common cold. or even bacteria. Most of these things are not normal biota that have now been given an opportunity to cause infection. There are some rare cases, though, of fungal sinus infections. So here's that summary table of sinus infections. So let's move on to acute otitis media, or ear infection. The ear infection is going to again be a potential outcome from a common cold. The inability to move mucus allows for the buildup of microbes in places that could cause harm. So the idea is the inability of the movement of fluids and ultimately in and out of the ear illustrates that there could be now the development of an ear infection. So ultimately we see that this biofilm will develop and cause more infection, but then becomes much more difficult to treat. So what are signs and symptoms? Well, the feeling of fullness or pain in the ear and loss of hearing. Young children are by far the most susceptible to this and will often become irritable, have trouble sleeping, eating, or even hearing. In bad scenarios, the eardrum may even feel so much that it wants to burst. Treatment, again, would be watchful waiting for 72 hours, but then we may start using techniques to eliminate symptoms and recurrent infections. So here's that illustration of, again, that middle ear. So note how we can have that eustachian tube inflammation that allows for a limited movement of the resources in and out. That allows now for a more likely scenario of infection. So here's again causes of ear infections. The next thing we should talk about is pharyngitis, or inflammation of the throat. This inflammation of the throat causes again pain and swelling, which makes things like swallowing difficult. This can again lead to things like hoarseness in many viral cases, but many bacterial cases can be excessively painful and are often accompanied by fever, headache, and even nausea. So you can see here again pharyngitis and tonsillitis here. You see the inflamed tonsils. Again, the reddening of the back of the throat, as well as this blotty rash here illustrating infection. So you can see here Streptococcus pyogenes is by far one of the most common causes of pharyngitis. I want to point out, again, this is that same gram-positive causi that we talked about way back in the disease 1 presentation. So the idea here is this is a facultative anaerobe. It can produce, again, slime and capsule. Untreated, again, it will spread quite readily and cause things like systemic fevers and ultimately significant damage. So it's important, again, to understand that these virulence factors make it difficult for the immune system to kill, and ultimately these infections can last a long time and cause significant damage across the body. So here's again a summary of pharyngitis. So viral tends to be much less severe than strep pyogenes. Again, if you have a strep throat infection, you must seek treatment so that it doesn't spread throughout the body. So let's move on to something known as diphtheria. Diphtheria, again, a bacterial disease that could easily be protected against through vaccination. Again, a DTaP or Tdap provides protection against diphtheria. That's what the D stands for. I do want to point out that for a very long time, diphtheria was a major concern because it had significant morbidity and mortality. So this immunization has offered huge amounts of protection, and thus people that would not survived before can survive today. So the idea again, vaccines save lives. Ultimately, epidemics are small, but we do see them typically due to an inability of people to get vaccines. So again, religious communities, specific areas where anti-vaxxer movements are common, those are where these outbreaks usually occur. So what is the causative agent of diphtheria? Well, it's a bacteria called Corynebacterium diphtheriae. Again, it's a non-endospore forming gram-positive club-shaped bacteria. It again produces a sore throat and lack of appetite and low-grade fever. But we see the pseudomembranous forms on on the tonsils or pharynx that can allow for the blockage of the pathway, which stops breathing, naturally resulting in death. So again, that vaccine, the DTaP, very necessary for children, and then the Tdap booster for individuals throughout the rest of their life. So diphtheria summary sheet listed here. So let's move on to another common respiratory pathogen known as whooping cough. The whooping cough is caused by Bordetella pertussis, which again has a characteristic kind of path in terms of how it works. We have the catarrhal phase, which again the bacteria in the respiratory tract causes basic, simple cold symptoms. But then we have our paroxysmal phase, which is uncontrolled coughing, resulting in a whooping sound. Again, we have this very small window of opportunity for breathing, and as a result, we try to bring in as much air as possible, which is going to make a whoop sound. And then lastly, if the patient doesn't die, we see convalescence, where again the bacterial numbers decrease and so do the signs and symptoms. I want to point out that children are by far at the greatest risk for getting this and dying from this. The idea here is that they're going to have a very hard time in naturally fighting this, and so they're going to have much more extended times with the signs and symptoms. There is concern of death with this because, again, that excessive amounts of coughing can result to breaking of blood vessels that can lead to things like hemorrhages in the brain, which can and will be fatal. So naturally, the cause of this is Bordetella pertussis, which is another thing that can be protected against in that DTaP or Tdap vaccine. These are small gram-negative rods that are aerobic and fastidious, meaning that they're actually semi-hard to grow, but they do grow quite well in the respiratory pathway. The real concern actually comes from the two different toxins. The first toxin is the pertussis toxin, which produces excessive amounts of mucus, and then the tracheal cytotoxin then destroys ciliated cells. So the body has no natural way of moving this excessive buildup of mucus, and the result is excessive amounts of coughing. So again, the pertussis vaccine is very important. Overall, again, adults aren't likely to have many signs or symptoms, but can be carriers. So it's important for, again, adults to protect offspring by getting these vaccines. Again, a DTaP or Tdap protects you against lots and lots of different pathogens, really 3 of them, all of which can kill you. So here's that summary sheet again for pertussis or whooping cough. So let's move on to influenza. We will talk a lot about influenza, and we're not going to do a huge amount on signs and symptoms because we've all had the flu. But I want to point out that the flu has traditionally been deadly in the past, and that many people, again, have died in many flu outbreaks out there. So I want to point out that we've had a pretty good run here of not many significant outbreaks of the flu. This may be a change in the way medicine works, or it may just be a lucky draw in terms of what we're seeing out in nature. The idea here, though, is the flu can and should be taken very seriously. So I want to point out the flu is actually going to be a respiratory infection, but we can see things that lead to some concern with the gastrointestinal tract, right? So I want to point out that H1N1 is going to be an example of one of the more severe flus, also known as swine flu, by the way. So not all patients behave the same, so not all of them had fever. Many of them also, again, had gastrointestinal distress and had multi-organ system failure. The reality is flu doesn't always present the same way, and as such, there can be significant risk. So let's point out, again, we often name flus based off of 2 features, the H, which is hemagglutinin, and the N, which is neuraminidase. So these 2 features are necessary in allowing for invasion of mucous membranes and then thus the establishment of the viral infection. So again, H, or hemagglutinin, allows for agglutinating action on red blood cells, which causes significant disruption. But neuraminidase is actually what's really important in breaking down that mucous membrane, which allows for that penetration. And so the idea is H and N play a big role in the severity of the disease. And so we give the different versions of these numbers. So we have all these different types of flu, like H1N1, H3N6, whatever combination we could see. So, one of the things that we should probably get into, and this is a bigger concept that applies to a lot of viruses, is this idea of how viruses can change somewhat quickly. There will always be something known as antigenic drift. Antigenic drift is the normal kind of change in the features of the microbe, in this case the virus. Again, this is that general kind of mutational change that results in surface feature change. But what we're more concerned about here is the antigenic shift, where we have two different flu viruses infecting the same host at the same time. So two different viruses in the same cell. And so what we end up with is this new random combination, because you're not going to just get each one of those things out alone, you're going to get a mixture of them. And so this mixture reclassification will allow for stuff that we have maybe never seen before. And as such, we have no protections against. And this is where our real concerns for an influenza pandemic come in. So notice this illustration. The swine is actually a wonderful place for viruses to go through this antigenic shift. So we have the duck flu coming in to the pig, but also the human flu. And so what we end up with is this duck-human flu hybrid, which again, we don't have as much protection for because we don't routinely get the duck influenza. And so this is a new version of the flu that we, again, wouldn't be as prepared to fight. So prevention of the flu is a big important thing, and really we have annual flu vaccines. I want to point out the flu does change a significant amount year to year, and as a result we have to make an educated guess about what we're going to see each next season. And so the idea is sometimes we get it wrong, but I want to stress to you that any protection is better than no protection, and so it's very, very necessary to get the flu vaccine because it can help you survive. I want to point out that many people accuse again the flu vaccine of causing the flu. The flu vaccine should not cause the flu. What's going to happen is you're going to have flu-like symptoms because many of our signs and symptoms of infection are tied to things like fever and inflammation, those system-wide events. So yes, you're going to feel like crap after you get the flu vaccine, and it's because the vaccine is being perceived as a threat and the body is trying to fight it. Again, people don't routinely get the flu from the vaccine. So here's that summary on influenza. So let's talk about tuberculosis. Tuberculosis is going to be a disease that we've been seeing throughout history and has been noted throughout history. The idea is this is something that the human population has been aware of and concerned of for a very long time. But that also means that it's had a lot of different historical names, things like Captain of the Minute Death, the White Plague, even consumption. The idea is this is a pretty serious disease, and it took a very long time for us to get under control. We are seeing again more issues in recent years with reemergence of this disease, particularly drug-resistant strains, which is again very, very, very problematic for us. So with primary tuberculosis, or the initial infection, we'll see an infectious dose of around 10 bacteria, which is again very, very low. And what happens is the bacteria continue to grow inside of alveolar macrophages, resulting in the formation of a tubercle. Tubercles are going to again be basically a home for all these bacteria. And ultimately what happens is these things become necrotic and then later become calcified. And so we get these calcified lesions that develop. We call those lesions again tubercules. The idea is that initially the infection stays in the lungs, but can be spread into other places like lymph nodes, the intestinal tract, kidneys, bones, genital tract, brain, and even meninges. But then our big concern is the secondary or reactivation of tuberculosis, where again after time of hanging out and reproducing in the tubercle, we see the pathogen comes back out, and that reactivation allows for now a new infection. But now we have huge numbers and decreased immunity, and so these often become very severe symptoms, which include excessively violent coughing, greenish or bloody sputum, low-grade fever, anorexia, weight loss, fatigue, night sweats, chest pain. Again, all these things that we summed up in the past as being consumption. Untreated disease will have a significant mortality rate of around 60%. So what causes tuberculosis? Well, it's a bacteria known as Mycobacterium tuberculosis. This bacteria will form will be long, thin, acid-fast rods, and they are strictly aerobes. But in the lungs, we have plenty of oxygen. What's more interesting here is the length of generation time. Something like E. coli can reproduce in 20 minutes, while something like tuberculosis takes around 20 hours. So it takes weeks to months before colonies become very evident. The idea here is this is a very slow-growing disease, which allows for signs and symptoms to slowly accumulate. So many people aren't aware they have this infection. So here are some observations of Mycobacterium tuberculosis. Again, here's the cultural appearance, which looks like several small eggs kind of lumped together. But then the acid-fast stain, again, is the optimum way to look for it. So let's talk about transmission. Transmission is going to be through literally droplets that come through respiration. And the idea is naturally the pathogen will be transmitted via the air, but into the lungs of another person. And ultimately, this is going to allow for the establishment of infection. But there are some major connections in where we see these most commonly. TB is often attached to poverty, so people that have poor nutrition. And the poor nutrition and exercise leads to a debilitated immune system. And naturally, with no money, you have poor access to medical care. And that results then in potentially things like lung damage, which could allow for more infection, by the way. And then again, genetics would be a major precursor as well. So let's talk about how we look for or diagnose TB. A common strategy is TB skin tests. The idea here is that we can look for the pathogen by introducing the antigens associated with the pathogen. If we see a significant immune response, we would see significant amounts of inflammation. The idea is we can also do a blood test, which is becoming more and more common. If again a person pops positive on these tests, we often then do a chest x-ray to look for the presence of the bacteria in the tubercules. Again, if we see positive tubercules, that means there's been a significant infection, but we don't know if this is a current infection. So the next step is usually an acid-fast stain. From there, though, we would then often do some purposeful culturing to make sure and see if it's reactive to the antibiotics so that we know the best course of treatment. There are also new recent PCR techniques that can also help recognize this threat. So here's that illustration of the TB skin test. Again, introduction of specific proteins associated with the pathogen are introduced into the body. Again, significant inflammation illustrates that there has been an encounter with this threat before. And if we do have active tuberculosis, it is absolutely necessary to isolate the patient and start treating them significantly with antibiotics. And whenever we talk about these treatments, they're going to be very long treatments. We're talking months, okay? The idea here is we need to make sure that we eliminate this threat before the people are allowed to be reintroduced to other people. So where do we see rates of, again, TB? Well, overall here in the United States, it happens, but it's very rare. But that's not the case around the world. We do see several countries that do not supply us with data, which suggests, again, a large issue or lack thereof ability to provide data. But we also see areas with large concern and often also not offering a full set of data, like Russia, for instance. The idea here is TB is still readily found out in the world, but we see very few cases through our common screening techniques here in the United States. So here's again that TB rundown for you guys. So let's move on to pneumonia. Pneumonia is going to be again an anatomical diagnosis because we're looking for the inflammation in which again the alveoli fill with fluids. There can be several different causes of this, including again bacteria, viruses, or even potentially fungi. I want to point out that overall viral pneumonia tends to be much milder, but bacterial tends to be the worst. So the signs and symptoms of pneumonia typically start off with an initial kind of upper respiratory infection, which includes runny nose, congestion, headache, fever. But then we start to see the progression deeper into the lungs. Now we see things like chest pain, excessive cough, fever, even discolored sputum. The patient is going to start to look very bad very quickly because of the inability to move gases effectively. And so they become very pale and even may start to turn blue. The idea is this is something that can come on very quickly and as a result potentially very fatal. So you can see that accumulation of fluid in the alveoli that limits now our ability to do gas exchange. As a result, again, people are failing to get the oxygen where they need it throughout the body. So one of the most common causes here is Streptococcus pneumoniae. It's going to cover about 40% of all community-acquired cases. We also see viruses are very common, but there's a wide variety of them. We will have some cases of mycoplasmas, which are going to cause walking pneumonia, and then some rare offshoots like Legionella and HIB, as well as Histoplasma capsulatum. So let's start off with Streptococcus pneumoniae, which we've talked about numerous times at this point. Again, strep, chain, cocci, gram-positive, so they're again a chain of gram-positive spheres. These will typically try to form diplococci. It's not uncommon to just see a few of them chained together. The idea though is they do cause significant infection. I want to point out that this is something again widely carried. So usually this doesn't show up until immunity goes down in some way. So things like old age, seizing, underlying disease that is already affecting the respiratory pathway, diabetes, abuse of alcohol and drugs. These are the things that typically set off Streptococcus pneumoniae. And as a result, this thing grows quite readily. It's a polysaccharide, it has a polysaccharide capsule, so it doesn't respond to phagocytosis well. Again, it blocks complement. It causes significant amounts of inflammation and fluid to build up. The idea here is this thing can and will be pretty bad. And so vaccines are actually widely encouraged, especially later in life, whenever you're most likely to get this. The next topic is Mycoplasma pneumoniae. Mycoplasma pneumoniae is going to cause atypical pneumonia because these patients typically aren't bedridden. And so the idea here is these patients are often going to walk in and often walk out because this pneumonia, although uncomfortable, not usually life-threatening. Diagnosis for the acquired Mycoplasma pneumoniae is going to typically be done through things like PCR. The next thing I want to talk about is Legionella pneumophilia. Legionella was actually a very unique instance where we discovered a significant problem through an epidemic. The idea here is Legionella was first discovered in 1976 at an American Legion convention in Philadelphia. That facility was using a very large water-based cooling system, and so what happens is Legionella pneumophilia can widely grow in this fresh water supply, and as a result, again, whenever they aerosolize the water, they also aerosolize the bacteria. And the individuals attending this facility, mainly being elderly, were introduced to this pathogen, which caused, again, a respiratory infection. So today we still see it as a concern for inhalation of tap water, the use of still cooling towers, spas, ponds, or even, again, inhalation of fresh water. The illustration here is this thing can be a concern if you're older and you inhale infected water. So let's move on to Histoplasma capsulatum, also known as Darling's disease, Ohio Valley fever, or Spelunker's disease. This is a dimorphic fungi routinely found, again, in caves, and as a result can easily be something seen here because we have huge amounts of caves here. The idea is that you go down in the cave where this mold grows out of control, you inhale this, and if your immune system is not up to snuff, you get a chronic pulmonary histoplasmosis, which again leads to similar signs like tuberculosis has. So the idea is this is a fungi that many people around here would get through caving. So here's that summary of, again, community-acquired pneumonia diseases. A continuation of that summary. On to healthcare-associated pneumonias. As we said before, healthcare-associated infections are actually pretty common, and pneumonias are actually still very common here. There's an estimate that around 1% of anybody going into the hospital will develop pneumonia that is a result of being introduced to pathogens in the hospital. And so with this, these people typically have a very high mortality rate, so around 30 to 50% of these people die. I want to point out that there are multiple different types of causative agents that we usually wouldn't see, and many of these infections are introduced through improperly cleaned ventilation resources, things like endotracheal or tracheostomy tubes that are not properly handled. I want to point out some of the more concerning things. You guys, again, watched a video about KPC, or Klebsiella pneumoniae. This is one of those commonly seen things here. So Klebsiella pneumoniae carbapenemase is one of the bigger concerns in these healthcare associated pneumonias. So ultimately, again, most cases are due to aspiration from the upper respiratory tract. So elevation of patient's head helps reduce aspiration. Deep breathing and frequent coughing should be encouraged. Proper care of ventilation and respiratory equipment, and then the use of antibiotics if we suspect a patient is highly likely to develop this pneumonia. So again, being a good steward of drugs is necessary, but also using drugs to save lives is necessary. So this is a good, happy way to do this. So again, here is that rundown on healthcare associated pneumonias. And here's the general rundown on respiratory infections. Here's a continuation. And the last visual representation of these infections.